Okay, so this is part 2 of the Pete's Talks. This is a talk on GI. Let's start out with a this versus that case, which isn't really a GI case as much as it's an abdominal plain film case. So we've got two different umbilical catheters, one that's going straight up and one that's going down and then up, sort of like that. And the question is, which one's which? In other words, which one's venous and which one is arterial? Now, the way that I remember this is that you've got 3-vessel cord, normally anyway, which is one vein and two arteries. And you've got two iliac arteries. And you've got one vena cava. So the artery is going to be the one that goes down, going down into the iliac artery before it comes back up. Something like that. So just taking another look at this anatomy, we've got two arteries and one vein. For the arteries to hook up into the vena cava, or for the arteries to hook up into the iliacs, they've got to go down first before they come up, whereas the vein will go straight up. So that's probably the most common question, which one's which. The next most common question is probably, where do you put the umbilical arterial catheter? Does it matter? Of course it does matter. It lends itself well to multiple choice. And the way to remember it is that your whole objective in life when you're placing these catheters is to avoid the renals, is to avoid basically the major arterial stuff that's going on right here, specifically the renals. You don't want to park your catheter in there and end up causing a problem. So you either want to go low, underneath of them, like L3 through L5, or you want to go high, above them, like T8, T9, T10. And the way to remember that is 8 is great, so 9 is fine. 8 is great, 9 is fine as far as how high you need to be. In between this is the no-go zone. All right, next case is an actual GI case, is an ultrasound case. There's only a few things with regard to GI that you can show on ultrasound. I'm going to try to show them all. This is the first one. So you probably immediately recognize this as a pyloric channel that is thickened. So let's talk about some of the trivia that can be asked about this. The first thing is, what's the clinical history? And this is very helpful for eliminating distractors or tuning you into what they're going for. Patient's going to be vomiting. Are they going to be vomiting bilious or non-bilious secretions? And the way to remember that is, bile is getting dumped in down here, right? It's getting dumped into the duodenum. But this is an obstruction here, so the bile can't reflux back into the stomach. So you've got just gastric secretions, which are non-bilious, so this is a non-bilious vomiting. And that's going to be different than the bilious vomiting we're going to talk about later. So that's the first thing to know. The second thing to know is, when does this happen? There's a peds pathology, tumors, GI stuff, bone tumors, lots of different stuff is very timing dependent. It's very useful to know how old the patient is. It's especially useful if they're kind and they give you that information and the question header. Let's just mark right off some of the distractors. So HPS occurs in a specific time interval, and that's 3 weeks to 3 months. So that's when you want to see it. In other words, you are not going to see this in a newborn. So if the question header is 2-day-old with non-bilious vomiting, that doesn't cut it. That you're going to have to think about some other stuff. You're not going to be thinking about HPS until you get to about 3 weeks. Lastly, the last thing that can be asked is how thick is too thick and how long is too long. The way that I remember it is 4 and 14. 4 for thickness, 14 for length. And in practical terms, it's on a spectrum where if you have a 3-week-old, 3 might be too thick. And if you have a 3-month-old, 4 might be normal. But for the purpose of multiple choice, 4 and 14 is the way to remember it. So non-bilious vomiting, 3 weeks to 3 months, 4 and 14. So here's the next case, showing a small bowel obstruction, bunch of dilated air fluid levels here, and then we're going to get an ultrasound and we're going to see that thing. sort of looks like a kidney, all right? Maybe, can I convince you of that? This is probably the trickier way to show this pathology. When you turn the probe over, then it looks like a target, which is more obvious. It's an easier way to show it. So this is intussusception, of course, and just like HPS, there is a timing interval that is critical for this. So instead of being 3 weeks to 3 months, this time we're 3 months to 3 years. And deliberately sort of stack them like that in a way that's easy to remember. So as HPS ends, intussusception begins. H becomes before I in the alphabet. Immediately before it, in fact. So that's the way to remember that. The next thing is that all targets are not created equal. So anytime you see a target, the first thing that you should do is measure it. If it's less than 2.5 centimeters, that may be a small bowel to small bowel intussusceptions, which can be transient and doesn't necessarily mean anything. Those are not going to be the ones that get reduced with an air enema. The ileocolic ones are, and they are typically greater than 2.5 centimeters. So here's an air enema if you haven't seen one. So this is the first picture here. We've started to put air up the butt, and you can see this area right here. That's the obstructing point, and then we can push that around until we end up getting air everywhere. So what do you need to know about air enemas? The first thing you need to know is the first thing you do is you get a plain film. Why do you get a plain film? You want to rule out a perforation. Obviously, you don't want to be jamming a bunch more air into somebody's butt if they've already had a perforation. It's just going to make it way worse. The second thing is, and this is obviously not going to be you because I went into radiology to avoid touching patients, especially screaming kids, but if they have peritonitis based on exam, that's a contraindication. So that would have to be provided for you in history, or you would have to say on multiple choice that you would do an exam, whatever. I don't even know how to do an exam for peritonitis, and you probably don't either. But you could say on multiple choice that you would evaluate clinically for signs of peritonitis. Air tends to cause less peritonitis if you do end up, because there is a certain risk of perforation with the procedure relative to water-soluble contrast. You would never use barium in a situation where you thought that you might cause a rupture. The last thing to know is that there is a pressure limit. So if you've done one of these things before, when you're pumping the thing up, sort of looks like one of those, well, probably different machines, but the one that I have used, it sort of looks like the pumper on a blood pressure cuff, and it has a little gauge also. You don't want to exceed 120. That's typical limit. You may see slightly different numbers. 120 is the one that I would remember. So just to recap, remember I said timing is very important. Timing. So don't forget about that, and that's going to be a recurrent thing throughout PED. So let's review. So HPS we said was, remember this is the letter that comes first in the alphabet, 3 weeks to 3 months. And then intussusception, right after that, 3 months to 3 years. All right, next case, we'll do some bubbles. This is popular in PEDS, right? So got a double bubble and a triple bubble. For the purpose of multiple choice, there's only one answer for a double bubble, and that's duodenal atresia. And for the purpose of multiple choice, there's only one answer for a triple bubble, and that's jejunal atresia. You may read that there is a differential with different things. Forget that. That may be practical for real life. For the purpose of multiple choice, double D, DD, double for duodenal atresia. And then the other one's the other one. All right, so which of these is more associated with additional atresias and why? So let's talk about the mechanisms for duodenal atresia and the mechanisms for jejunal atresia. The mechanism for duodenal atresia is a failure to cannulate. Well, what does that mean? So when you start out as a blob of cells, you have basically solid viscous, or your tubular organ, your bowel is solid, and then you have an apoptosis thing that goes on where it basically rotor-rooters out the middle. Well, if that fails to happen at a certain point, you end up with something like that. So that's your duodenal atresia. It's a completely different mechanism than your jejunal atresia. Your jejunal atresia is when you've had a vascular insult, you've thrown an emboli. You've thrown a clot. You threw a clot, and that ends up nailing some vasculature like this right here. Of course, that takes it out. You end up infarcting a portion of the bowel. It gets resorbed in utero, and you end up with a segment that's missing. And you can imagine that when you're throwing clot, that you probably would throw multiple clots, so you'd have multiple segments that were out. So you could have part of your ileum that was out, part of your jejunum that's out, etc. Totally different mechanism. All right, so let's do some trivia here. Double bubble, DD, duodenal atresia. This is a single atresia, right? So it's a failure to cannulate. Anytime you are wondering what the association might be for basically anything in peds, if you don't know, I would ask you to say with confidence Down syndrome. Down syndrome is a common thing. It's associated with lots of stuff. So if you don't know, the answer is Down syndrome. Polyhydramnios is going to be seen also. Just a quick refresher on how to remember that. Remember that your amniotic fluid is basically piss. So if your GU system, if your kidneys aren't working right, you won't be making enough of it because you're peeing it out. So low fluid is bad kidneys. And then, as gross as it might sound, you are breathing it in and you are drinking it in utero. So if you can't drink it, then the fluid builds up, so you have too much of it. So too much poly, GI, not enough oligo, GU. Now, jejunal atresias, we said, were multiple atresias because it was a vascular insult, so you would expect to see them at multiple different places. And like I said, if you don't know what the association is, the answer is Down syndrome. All right, next case. This is another GI belly thing. We've got two vessels here and one there. And I will tell you that the one that has the fat around it is the artery. And you may be thinking, hey, that's on the wrong side if you're really paying attention. And just to point this out, if you haven't thought about it before, the artery should be on the same side as the aorta, and the vein should be on the same side as the vena cava. And in this situation, it's switched. So when you see them switched, you should be thinking about malrotation. These are malrotated, so everything could be malrotated. So something like that. This is an upper GI. You probably have done a bunch of these for malrotation. And you may remember that to diagnose that, you want to see the ligament detritus cross the midline right at the level of the duodenal bulb. And it's not doing that. So this thing here is supposed to be on this side of the spine at the level of that. And when it's not, you've got malrotation. So let's do some associations here, and then we'll talk about next steps. So I say non-bilious vomiting. This is something we talked about earlier. And let's pretend it's 3 weeks to 3 months old. You will say HPS in your mind, and then I will say, what's the next step? And you would say ultrasound, right? Something like that. All right. Now, what if I say bilious vomiting, right? So this is different. I told you we were going to come back to this. I say bilious vomiting in a newborn. You say midgut volvulus, because that's the bad thing. That's the thing you don't want to miss. And I say next step. You say upper GI. An upper GI for bilious vomiting that's going to have a midgut volvulus is going to have this corkscrewing duodenum. That is an ant mini. That is a surgical emergency. Think about that like a closed loop obstruction. So people who are malrotated are, it's more than just having small bowel all smashed on one side of their hemiabdomen. They also have a shortened mesenteric root, and because of that, you are susceptible for corkscrewing, and that's why they do that LADS procedure where they go in there and they cut that and they create some adhesions and it mats it down. It's supposed to prevent a midgut volvulus, because people who are malrotated are susceptible to this. It's bad news. It can kill you because it's a closed loop obstruction. You can infarct your bowel. All right, so let's talk about, we've done upper GI stuff. Let's talk about lower GI stuff. What happens when you put some barium in the pooper? So this is sort of the basic idea of what you can end up with. You can end up with something that's normal. You can end up with a microcolon. You can end up with sort of a short microcolon, or you can end up with a caliber change. So this is my idea for working through these. The first question I ask myself is there a microcolon or not? And then I have a differential based on that. So no microcolon is going to either be normal, Hirschsprung's, or a meconium plug. The presence of a microcolon, then you're going to think about, is it a short one or is it a long one? So you can have either ileoatresia or meconium ileus, or you can have colonic atresia. So long ones or short ones. Well, why would this be short? Because you don't have a colon, so it can only fill a little bit, and then the rest of it's not going to fill because you don't have a colon. So let's look at this again. I'll reorganize these things so that we've got microcolon and not. So the long ones here, ileoatresia and meconium ileus. What's the trivia you need to know? Ileoatresia, just like jejunal atresia, think about multiple infarcts because of vascular pathology. Meconium ileus, you probably remember from med school, step 1, step 2. This is the CF thing, right? They've got the thick secretions there, and they end up with meconium ileus. Colonic atresia is going to be short. It's going to look different than the other ones. Now, Hirschsprung's, remember that that's a failure of the nerve cells to migrate. And then meconium plug syndrome is the one they're going to try to trick you and make you think that that's meconium ileus because it has the word meconium in it. It is not the same thing. This is something that you see in diabetic, well, the children of diabetic moms or the children of moms that had MEG sulfate. It is not in CF patients. Do not choose that if that is a choice, which I would expect it would be, because that would be just too easy, right? Meconium ileus, meconium plug syndrome, they sound similar. Just don't mix those up. All right, so more about Hirschsprung's. Remember, this is a failure of those ganglion cells to migrate and innervate the distal colon. The affected portions of the colons are the one that is small in caliber, whereas the normally innervated colon appears relatively dilated. It's associated with Down syndrome, and the way to remember that is everything's associated with Down syndrome. It's more common in boys. Hirschsprung sort of sounds like a boy's name to me. That's how I remember that. So there's two basic ways to show it. One is this lateral. Notice that you can sort of see the spine here on a leg. That's how you know it's lateral. And the rectum sigmoid ratio is messed up. Well, how do I remember that? The rectum is what gives you your continence. It's the sac that holds the poop. When you gotta go, that's what's holding it. That's the part that's giving you your urgencies down there. And that normally will expand more than the sigmoid colon. Well, when that's backwards and the sigmoid is bigger than the rectum, that's abnormal. And remember, we said that the normally innervated portion actually appears more dilated, so the rectum's the part that's not innervated correctly. Anyway, it's backwards. The other way that they can show it is this sort of sawtooth pattern, and the reason that you see that is because it's like a mucosal spasm. It's not normal. So our classic history, they come in two flavors. The most common one is the newborn who's failed to have a bowel movement. The second one, which is much trickier, is the kid who got missed. He left, and then he comes back super duper sick, and he's got like neck bowel. Now, here are a couple of other associations you need to know as far as lower GI stuff. If you've got a kid with no asshole, you need to remember that that is associated with Vactorel. Okay, that's the A. And the other thing to know is that babies with no assholes are associated with tethered cord. So I say in perforate anus, you say screening ultrasound for tethered cord. All right. Next case is just an Aunt Minnie. You see this big calcified blob in the middle of the abdomen. It's a very characteristic look to it. This is a meconium peritonitis. Basically, you've had a sterile perforation in utero, and it's resealed itself, walled itself off. It can be seen in the setting of atresias or meconium ileus. Typically, there's no leak at birth. All right, next case. So I'll tell you that this kid has abdominal pain and that you see this on CT. Zoom in. I will also tell you that you scrolled up and down and you saw the appendix and it was normal. So this is the Meckel's diverticulum, which can get Meckel's diverticulitis. These can cause obstruction. They can act as a lead point. When do you think about lead points? When it doesn't obey the intussusception rule, which remember is 3 months to 3 years. So early on or later on intussusceptions, you think about lead points. So remember there's this rule of twos that this is a multiple choice thing. It occurs in 2% of the population. It's typically 2 inches long. Usually has symptoms before the child is age 2, etc., etc. So is there another scan you can do? Now, throughout the lecture series, I've sort of done this thing where I make fun of family medicine for being stupid, which they usually are, and it's usually a nuclear medicine test. So is there a nuclear medicine test that you can do for Meckel's? Yes, there is, and it's called a Meckel scan. So what is a Meckel scan? You may remember that is basically it's pertechnetate, right? Pertechnetate goes to gastric mucosa. So will it localize to all Meckel's? No, it won't, because only a small percentage of Meckel's actually have gastric mucosa. The good news is the ones that have pain and bleeding and those kinds of things typically have gastric mucosa in them, so it works on the ones that are symptomatic. All right. Do all Meckel's have gastric mucosa? No, about 30%. So that's seen in about 30% of the symptomatic cases. All right, so some more trivia here. When do you do the scan? All right, so this is sort of the opposite of a bleeding scan. You know, you do a bleeding scan when the patient's bleeding because you want to try to localize the bleed. You do a Meckel scan when the patient is not bleeding. That's a trick. A lot of people will fall for that. What do you do if they are bleeding? You do a bleeding scan. So that's the way to remember that. Do you have to pre-treat them? Most books will tell you yes. You're supposed to give H2 blockers or glucagon, those kinds of things. Well, why do you give the glucagon? Glucagon is to slow gastric motility because it's going to localize normally in the stomach. The H2 blocker is done to block the secretion of pertechnetate out of the gastric cells and makes it stick around a little bit longer and makes it easier to do it. There's another thing you can give called pentagastrin, which enhances the uptake of pertechnetate by the gastric mucosa. It also stimulates GI activity. Lastly, if you don't remember from your internship what H2 blockers are, cimetidine, like the ones that end in INE or DINE, the dynes, those are your H2 blockers. Expect that they're not going to say H2 blocker. They're actually going to give the name of a drug. Why would they do that? Because the people who have been involved in the boards for 30, 50 years, forever, want radiologists to pretend they're real doctors, so they love to ask medication questions. So get yourself a list, write that stuff down. Remember that cimetidine, redantidine, or however you pronounce that. Things that end in DINE are your H2 blockers. All right, next case. We've got something that sort of looks like we might have some neck going on here, some bubbly stuff. So how can you tell if it's neck versus poop? Practical pearl is you call up the floor and you say, has the kid eaten or not? If he hasn't eaten, he doesn't have poop, and then it's more likely to be neck. Sometimes you just can't tell and you just have to watch for serial imaging. You know, is that bowel loop staying similar? Is the poop should move, right? So we get a lower GI study, and we see this right here. See that? What do you think of that? So it's a stricture, right? So this is a neck stricture. So who gets neck? The most common answer that you would expect as a premature kid. 90% of them supposedly within the first 10 days. Low birth weight, right? But they can also, and this is the trick one, it can also be cardiac. So if its kid is sort of like otherwise normal, full-term kid, normal weighted kid who's getting neck, you can think about like doing cardiac screening. Next step, cardiac screen, if they would tell you that. It would be a really dirty trick. Also, anybody who's had prenatal hypoxia issues, and remember that I mentioned earlier that Hirschsprung's, the kids that go home and then come back. So what does neck look like? Pneumatosis, which was the case that I had showed there, that's the obvious way to show it. The sneakier way to show it is focally dilated bowels, especially when it's in the right lower quadrant. Allegedly, the terminal ileum and right colon is the most commonly affected by neck, so that's where you would see that, and it would have to be shown as multiple serial exams where you've got that focal dilated bowel that's not moving. Featureless small bowel, this would be really hard to show on a low-resolution monitor, but it is a thing. Especially if it was like, is that listed in a choice, multiple choice, that would be one that I would pick. And unchanging bowel gas pattern, that was something that I mentioned before. This is the most useful probably practically, other than when you see pneumatosis. So mentioned this once before, pneumatosis versus poop. The age-old question, remember to ask, is that kid been fed? No poop equals no, or no food equals no poop. And then watching it on serial exams, does it stay still? Poop should move. All right, so that's the end of the GI talk, and the next talk is an MSK talk with peds